Well, we are at 8, so why don't we get started? Welcome to Grand Rounds. Delighted to have Chris Sadler talking on an infectious disease topic. And to introduce Dr. Sadler, we'll have Dr. Dave Andes, our Division Chief of ID. So Dave?
Thanks, Dr. Schnapp. It's my pleasure to introduce Dr. Chris Sadler. Many of you know Chris. He completed medical school at Wayne State before coming to the University of Wisconsin-Madison, where he completed internal medicine residency training, followed by infectious disease fellowship training. He's currently an associate professor and serves as the clinical service chief for the division, as well as our inaugural Transplant Infectious Disease Fellowship Program Director. Many of you know him as an excellent clinician. He's been awarded by the department as a star educator and star clinician, and I'm really looking forward to his update on C. diff.
Thank you, Dave, for that introduction. So I'm going to jump right into it. I'm super excited to talk about C. diff today. This is one of my favorite topics to talk about because everybody's tired of me around me talking to them about it. I get new people, so I'm really excited. So I'm going to talk about guidelines, updates, and beyond. I don't have any significant disclosures, no financial, anything like that. So let's jump into it. I really want to focus today on I want to touch on current testing options and their limitations. It's now easy to overdiagnose C. diff, which is different than in the past. I want to summarize the current guidelines-based treatments for C. diff because the guidelines recently have changed a lot. We actually have a couple new tools. It's not just Vanco, Vanco, Vanco FMT anymore. And I want to really focus on treatment options that decrease recurrence and promote their use as early in the course of infection as possible when we still have the possibility to kind of pull out of a recurrence spiral. So I'm going to kind of gloss over this. The history, I'm required to say this, C. difficile, Clostridioides difficile, is a gram-positive spore-forming anaerobic rod. It's incredibly hardy in the environment, but it was named because it was hard to grow. First identified in 1935, but it really hit the global scene in the early 2000s when it exploded across the world rapidly with escalating not only frequency, but morbidity and mortality. It went from a nuisance to a worldwide #1 problem in hospital-acquired infections fairly rapidly. And it's able to acquire antibiotic resistance, which helped spread it. And there was also some hypertoxin-producing strains and whatnot. So the epidemiology has changed a bit over time. In 2011, we were sort of at our peak of C. diff. It was this horrible nosocomial problem. Happily, the incidence of C. diff has gone down a little, but is still incredibly high. And the kind of community onset, community associated, healthcare associated, but not hospital onset C. diff is much more common these days. And it's still the #1 hospital-acquired infection. And again, hundreds of thousands of hospitalizations, 13,000 deaths. It's a multi-billion-dollar problem. And really, the real problem is the recurrence. That's the absolute key of C. diff, is the recurrent nature of C. diff, with each recurrence heavily predicting another. And once you get past that first recurrence, it gets much worse. It really escalates at that point. And the other interesting fact is, although we don't think about C. diff necessarily as a fatal disease, it's more of a significantly life-disrupting disease, because the 30-day mortality is actually about 3% if you're under 65, but that goes up to 14% if you're 65 to 74. And once you're over 75, the mortality is about 20%. So this really preys on specific populations. And so who gets C. diff? I really want to drive home this multi-hit hypothesis. Just being exposed to C. diff or colonized with C. diff is not enough. You need multiple things to go wrong. And what you need to go wrong is you got to acquire colonization. So you got to be exposed in some way, usually through healthcare in some fashion. Then you need to disrupt the microbiome. You need to deplete or disrupt the normal microbiome. We're talking antibiotics, surgery on the GI tract, chemotherapy, those kinds of things. And then finally, you need to have a poor immune response. And how much of that plays into it really is on a spectrum. And so who gets C. diff and who gets recurrent C. diff? People over 65, #1 risk factor. Immunocompromised hosts, much more likely to get it or recur. How severe your C. diff episode is. Very severe C. diff episodes predict that you're going to do poorly with C. diff in the future and recur. So even a single super severe C. diff episode needs to be taken extremely seriously. And then the more times you've had C. diff, the more times you will have C. diff. So again, that recurrence issue. I just like this pictograph that kind of shows that theory very nicely. It shows you got a normal microbiome, you'll be all right. But when you get disrupted and you have the susceptible microbiome, then you get colonized with C. diff. Now you've got kind of growing C. diff, toxin production and harm. And you've kind of got two things that can happen when you get treatment. You can get lucky and you get treated, and then your kind of microbiome restores itself over time. You don't have recurrence again. You can also get stuck in this cycle of on-off treatment until you find a way to pop out of it, which is usually advanced therapies like microbiome restoration. Why is the microbiome so important with C. diff? We all know the microbiome is important. That's a cool buzzword, microbiome, but sort of, I like to think of it this way. There's two things. There's colonization resistance, which can also be called a competitive exclusion. So just, we have this massive microbiome, trillions of bacteria. They outcompete, they use the kind of niche of the C. diff. But the other thing is really bile acid centric. So when we use the good bacteria, bad bacteria trope, the good bacteria in our colon are kind of synthesizing secondary bile acids. They're converting primary bile acids to secondary bile acids. And secondary bile acids are very inhibitory to C. diff growth and proliferation and toxin production. Primary bile acids are not. So when you kill off these good bacteria like your Firmicutes and whatnot, what happens is you lose those secondary bile acids. And then you get a very pro-C. diff environment where C. diff is proliferating. And this is really an important factor in the pathophysiology of how you go from C. diff colonized to C. diff infected. And I really want to drive home that C. diff lies on a spectrum. And I always talk to patients about this. The spectrum of kind of having C. diff in your colon is anywhere from totally asymptomatic colonization, which could come and go briefly or be somewhat persistent. And then it kind of grows to maybe some diarrhea, maybe it would go away on its own, to significant diarrhea requiring treatment, up to severe disease, and then finally fulminant disease like megacolon perforation and death, which is quite rare, but obviously catastrophic when it occurs. And that's important for testing, right? Because C. diff colonization is much more prevalent than people used to think in adults. So it varies wildly by what ward you're on, what kind of patient you are, what's been going on with you, and even hospital. But something like 20% or more in adults is actually pretty common and likely. And once you get into sort of an ICU or even worse, a heme or BMT ward, colonization is very common. And this is bad news because just detecting C. diff is not enough to know whether C. diff's the problem. And it'd be fine if people didn't have diarrhea, but I mean, what's one of the most common things in a hospitalized patient? No hospitalized patient is ever having the right number of stools. They're either constipated or having diarrhea, and almost never in between. So, diarrhea is happening in about 30% or more of hospitalized patients. Over half of our transplant patients at any one time have diarrhea. And there's an almost endless number of reasons somebody might have at least transient diarrhea, particularly in the hospital. So it's very statistically plausible that you could be colonized with C. diff and have diarrhea and have no causation in there. You just happen to have both. And so that represents a problem because we really don't have a gold standard test. And that is kind of a killer. In the olden times, it was all about how hard it was to detect C. diff when we were using old toxin EIA assays. You were doing 3 stools and, you were missing C. diff, but that's not been the case for a very long time. But those times kind of haunt us, that there's this feeling that we're going to miss C. diff. And so testing can there's no gold standard. There's no perfect test that tells us exactly who needs treatment every time. And you can split C. diff tests into kind of 2 groups. There's colonization tests, and then there's direct toxin tests. And colonization tests, if you look at this, the great thing about colonization tests is they're wonderful at ruling out C. diff. So a negative colonization test has basically 100% negative predictive value for C. diff. So every once in a while you have to, not any test can fail once, but really these are exquisitely good at telling you there's no C. diff present, but they don't tell you if the C. diff present is harmful or not. So common C. diff colonization tests that you'll see are the GDH antigen, which is just a conserved on almost all C. diff. So even non-toxigenic C. diff will be positive for GDH. So we use here the nucleotide amplification testing, the NAT, which is a PCR, which detects specifically the toxin B gene. So you at least know there's plausibly toxigenic C. diff present, but there's no causality. You don't know that it's producing toxin. You don't know where it's at. So again, a wonderful test to rule out C. diff, but a positive test still leaves you having to decide clinically if this is C. diff or not. Then there's the most commercially available direct toxin tests, the EIAs, which detect toxin A and B freely in the stool. And these tests are sort of the opposite of a colonization test. A positive test is extremely meaningful. That's probably the easiest way to know somebody definitely needs C. diff treatment. You could get even more granular than that, but it's not worth it. Knowing somebody has a positive toxin EIA is plenty to think, okay, I tested them for some reason. Now they're producing toxin. I think this is C. diff that definitely needs to be treated. But the problem with these are there are people with a negative test that still need to be treated. You can see the sensitivity is as low as 57%, as high as 80%. But the fact is you will have people that are colonized but not producing toxin that still need treatment, and you still have to use your clinical judgment. And then the final test that I want to talk about is the CNNA, so cytotoxicity assays. So these are called, I call these gold standard adjacent, or as close as we get to a gold standard, but these tests are a problem. They're wonderfully functional in that I believe their answer, but they are a send out test that goes to an alternative lab. So they take about 3 days to come back. So these are for real messes where you can't tell if they have C. diff or not, and it's important to know. So what they do is they actually take a filtrate of your stool. They look at antitoxin. So, and they take these vero cells that mimic colonic cells. And one set of vero cells has a bunch of C. diff antitoxin, neutralizing antitoxin, and the other has no antitoxin. So if you put a bunch of stool on both these and you get cytopathic changes on the ones with no antitoxin and no cytopathic changes on the one with antitoxin, then that is incredibly predictive that this is real C. diff. So, that's kind of the closest we get, and you should use those fairly rarely, but you probably should use them every once in a while to try to tease out what's going on. So testing at UW, which this is now incredibly uncommon. So most centers have gone to 2-stage testing, but I am going to talk through our testing strategy, is essentially a diagnostic stewardship-based testing strategy. So it says only test people that you think have C. diff. If you detect C. diff toxin by toxigenic C. diff by PCR, then you treat them if positive. So this relies on you guessing who has C. diff really well. And so there's a hole in that, but so many people have gone to 2-stage testing. So this is what you'll see from outside facilities mostly. And the idea is it might help. So you first do a colonization test because of their wonderful negative predictive value. So diarrhea, C. diff colonization tests like PCR or GDH. If that's negative, C. diff is ruled out. So just move on. If it's positive, then you move on to a toxin specific test. So you look for free toxin with an EIA. And if that's positive, you have a slam dunk C. diff case and you can feel really good about it. You know you have to treat this person. The con is that you're going to get into this corner with the little who knows guy, where the toxin is negative, but the PCR or the colonization test is positive. And those people are either colonized or have actual C. diff, and you need to use your own discretion in figuring that out. So ultimately, you're going to find at some percentage of patients, you got to guess on your own as a clinician whether they have C. diff or not, but this does maybe help a few. Some of the people have a more firm diagnosis. So you may see these out in the world. Recurrence testing is even messier because we have the same problems, but more. So we know that about 60% of people treated for C. diff will still be PCR positive at the end of therapy. And we know most recurrences are in the first few weeks after treatment. So testing in these cases is really for the negative predictive value. So if you retest somebody and their C. diff PCR is negative, it's definitely not C. diff. So that's helpful. But again, most or 40 or more % of people will still be C. diff positive. And within that, if you're talking about a colonization test, some of them need treatment and some of them don't. So sometimes this is easy. They got a bunch of clindamycin for a tooth or something. They got antibiotics for C. diff. They got better. They stopped treatment. They got worse again. But life is often messier than that. And as somebody who treats transplant patients with a cadre of reasons to have diarrhea, this often gets difficult. And especially when you're seeing somebody multiple tests in, they start to lose track of how they responded to treatment and things. So always remember when you're approaching maybe recurrence, a negative test is super helpful. A positive test, you still have any number of possibilities. This is recurrent C. diff. This could be post-infectious IBS, where they just have kind of inflammation of the gut. They're not processing well. This often presents as they have a lot of diarrhea around food, and then it will calm down for periods. And they just need to sort out with time. And then always consider at every time, was this ever really C. diff? Sometimes you start to delve into it and you're like, oh, they never really had C. diff, or it's been a long time since they had C. diff, but they're just colonized now. So there's many ways to approach this. You can just make a clinical diagnosis with you can start treating and gauge if their response to therapy is appropriate, and that can tell you a ton. And then in super rare cases that are a complete mess, advanced testing like a cytotoxicity assay may be helpful. So again, my testing recap, the things I want you to remember about testing is there is no gold standard. Tests can either be direct toxin tests like an EIA, toxin EIA, or they can be colonization tests like our C. diff PCR or GDH. A positive colonization test doesn't automatically mean C. diff, and a negative toxin EIA does not automatically mean there's not C. diff. So you have to use clinical judgment in it no matter what. And why do we care? Because people always say, like, why don't we just treat C. diff if it's there? Like, shouldn't any detection mean that we have to kill it? And the reason we don't want to do that is because we probably can't decolonize people. That's not what's effective. What's effective is your microbiome protecting you from C. diff. So again, 60+% of people after treatment are still have detection of C. diff. C. diff's hardy and will persist. And what you're doing is actually depleting the microbiome. So even though you're beating up the C. diff with anti-C. diff therapy, you're also killing all of the good bacteria that are supposed to be holding C. diff at bay. So you may in actuality predispose them to C. diff disease with C. diff treatment. So you're better to let their microbiome lie than try to treat with the absence of disease. Well, let's kill some C. diff, right? Treatment time. The key facts about treatment are, again, C. diff is a multiply recurrent infection. Recurrence is the major complication of C. diff. And over half of recurrent C. diff cases are readmitted. So C. diff is an expensive problem. So preventing recurrences is not only great for patients because C. diff is a plague to have, it's good for business. And risk factors for recurrence boil down very easily to age over 65, immune compromise, severity, or prior episodes. And I like to think through C. diff treatment using this multi-hit hypothesis of how we got to having C. diff or recurrent C. diff. Okay, C. diff's there, antibiotics to try to kill it. A poor immune response, now we have an monoclonal antibody against C. diff toxin. And then disruption of the microbiome, the biggest kind of factor in recurrence, there's microbiome restoration therapy. So let's talk about each piece of that. First, here's a list of everybody who writes C. diff guidelines that's important, and we're going to talk about initial C. diff infection. So you'll notice a few common things. One, fidaxomicin is now top of the list across all societies. You'll notice ACG, gastroenterology, kind of ranked them equally, and the other two said they prefer fidaxomicin. When you talk to the guidelines writers, this is just a wording difference. Everybody wants you to get fidaxomicin, but the gastroenterologists were more likely to admit that you may not because it's expensive. So they just elevated fidaxomicin into the first line. Everybody else said, try to get fidaxomicin, understanding it may not be feasible. And then everybody dropped Metro into the only for non-severe and only if you absolutely can't get something else. So first I want to talk about, and then bezlotuximab for prevention with high risk. So for, of course, classification, severe, non-severe, fulminant. Let's talk the antibiotics. So first, antibiotics just kill off, they beat up C. diff to stop toxin production and get clinical remission, and then hopefully prevent recurrence as well, but may not. So first, Metro is out unless adjunctively in fulminant C. diff, particularly with ileus, which is not evidence-based, but we do it because it probably doesn't hurt. So how did Metro get kicked out? Well, we all remember this is back to 2007. Dr. Czar showed that Metro was inferior for severe disease. You also notice it was inferior for non-severe disease, but nobody cared back then. The important takeaway of this was non-severe disease. With severe disease, clearly Metro is worse than Vanco. But then they started looking back at other studies. And so this is the Tavelumor study, which was a toxin binder that they tried to use. Fun fact, it actually helped prevent recurrence when it worked, but it didn't work that often, only about 40% of the time. But what they looked is when they combined all the treatment, Vanco was about 10% better than Metro straight up, no matter what. And using a lot of data like this, eventually we decided, you know, Metro's just not that good. So it comes down to a fight between Vanco and fidaxomicin, old guard and new guard. Not that Fidaxo is all that new, but it got priced astronomically enough. It took a long time to get any market share. So vancomycin and fidaxomicin have essentially equivalent short-term efficacy. Vancomycin works like a charm while you're on it. So it's excellent at short-term cure with a long-term obliteration of your microbiome. And that's why people think C. diff recurrence has been traditionally pretty high, or at least one of the factors. And again, about 20% after your first episode, 40 to 60% beyond as you recur. And it's cheaper than fidaxomicin by quite a bit, but not cheap, importantly. Only Metro is cheap. Fidaxomicin, however, has a lower 30-day recurrence rate with the same short-term efficacy. So it's not better, it's just equivalent, but with better recurrence. And the thought is that's because this non-absorbed kind of macrolide adjacent drug is very narrow spectrum comparative to Vanco. So there's a good amount of preservation of the microbiome. And this was the big pitch at the time when it came out. But the cost is thousands versus hundreds of dollars. So coverage can still be an issue. It's getting better with insurance companies having to eat the fact that it's first line now. And there is plenty of argument that there is cost saving still with the amount of prevention of recurrence. But again, insurance companies don't care about you and they don't want to pay. So they're willing to bet about the 80% of the time that the Vanco's cheaper and it works out. And I always like to say, your microbiome is like a beautiful rainforest. There's trillions of organisms. It's so diverse. The sheer number and the sheer diversity have caused this beautiful functioning kind of utopia. And C. diff is an invasive species. It's the zebra mussel of your gut. And using oral vancomycin is burning down the entire forest to get rid of C. diff. You know, it's just burn the whole thing down. And then you hope all those gentle, nice bacteria grow back and not the antiseptic resistant spore forming demon that is almost impossible to get out of environments. And so again, this is why not to treat colonization. And this is kind of the basis of why people sometimes get stuck in a recurrence cycle and why microbiome restoration might be the key. So let's look at hard brass tacks, fidaxomicin versus vancomycin, straight up studies. You can see clinical cure is defined as getting better at the end of therapy. So everybody did just as good with Fidaxo or Vanco, but you'll see that 10 or 11% absolute risk reduction when you're talking about fidaxomicin versus Vanco at 30 days. And that was in 2 giant studies in NEJM and Lancet. And when they looked at who got the most benefit, it was first episode and particularly in first recurrence. So using fidaxomicin early was the highest yield activity. There's a bunch of post hoc data that has suggestion of this, but it's still a mixed bag because at 90 days, fidaxomicin didn't look particularly better than Vanco. So really fidaxomicin won because of its better 30-day recurrence. And then here's an interesting follow-on that I just love. This is the Extend trial. So they took people that were at high risk of recurrence. They were 60 and older, should have been 65 and older, but they said 60 and older. Most of them were on first episode, about 80%. A few of them were on second episode, and almost none of them were on third episode. And you either got fidaxomicin, which is usually tablet BID for 10 days, but they spread them out. So you took a tablet BID for 5 days, and then you spread it out every other day for the rest of the tablets, which got you to day 25. And so they used kind of a phaco pulse and taper approach, but still using the same number of tablets because they figured it's so expensive, no insurance company will give you more tablets than that. And they compared it to a standard course of Vanco, just the 4 times a day for 10 days. And what happened was they achieved dramatically better outcomes. So the recurrence rate was 6% at 90 days, which is the lowest recurrence rate ever in a trial. And interestingly, they had the right recurrence rate in C. diff. Every C. diff trial always shows about a 20% recurrence when you use Vanco. And so it's really interesting. The sustained clinical cure with this sort of off-label dosing scheme of fidaxomicin is really promising, but it hasn't been used in a lot of studies since. This is the only study I can find that uses this. So I'm a huge proponent of this alternative dosing scheme to try to get the most out of your fidaxo if people respond very well early in the course. But more to come on these kinds of, and there's really no other studies of longer fidaxomicin pulse and tapers like we use Vanco for weeks and weeks on end and de-escalating kind of dosing. There's never really been a proper fidaxo taper. So the takeaways of first episode C. diff are really just that for antibiotics, the optimal is to use fidaxomicin because of the better recurrence rate. And I even prefer to use it on this off-label kind of 200 BID for 5 days than every other day till you run out. Very good is still any fidaxomicin. And then if you can't get fidaxomicin, then use oral Vanco. My tip here is that you have to treat C. diff fast. People aren't going to wait around for prior auths or the copay assistance program. I would suggest I have a pharmacist that can figure this out in clinic with me in real time. If you don't have that luxury, then what I would do is write scripts for both. And I tell the patient to call the pharmacy ahead of time before they pick it up and just see if the fidaxomicin is cost effective or not. If it's not, just move on to Vanco. You have to live in a realistic world, but I would at least try for the fidaxo. But you have to really consider the cost concerns can be astronomically different. So for first recurrence, we're starting to get into that danger zone. Now you've recurred. Everybody really prefers fidaxomicin at this point, but they say, or I don't know, you could try a long Vanco course. They took out that sort of just repeat the Vanco course because that wasn't leading anybody anywhere. And this is on almost no information. There's really not good studies for recurrent C. diff kind of therapies. There's been some in the VA that have been ongoing, but there's really nothing perfect in this case. So this is super expert opinion. So my opinion is if they had Vanco, then you can try a course of fidaxo in some way. Everybody should get bezlotuximab for prevention at this point if they haven't gotten it already. And then if they already got fidaxo, I'm pretty worried because we already kind of took our best shot at preventing recurrence. So you could try the fidaxo through a pulse and taper. You could try an oral Vanco pulse and taper just because fidaxo failed. They should have gotten Bezlo. If they already had Bezlo and already had fidaxo, then I'm definitely referring to ID or thinking about the fact that they're going to go down a multiple recurrence pathway. So they're in the most danger zone. And then in multiple recurrences, everybody admits that more antibiotics is probably not the answer alone, that you're probably using antibiotics to bridge to microbiome restoration at this point. And so again, antibiotics are just to cause symptom resolution and drive down bioburden. There's no evidence that which antibiotic you pick matters at this point. And I'll usually pick PO Vanco at this point because it's cheaper and because I can give a really long course of it. So that gives me time to get them under control and then also to get whatever FMT I'm going to use situated. And in this world where insurance companies don't want to pay for stuff, you don't really want them running out of fidaxomicin and having to see if they can get more fidaxomicin or not. So it's easier to just give them a Vanco pulse and taper so they have a ton of it till they get to MRT. So the antibiotic summary, what I really want to stress is Metro is gone. Put it out of your head. PO Vanco works great while you're on it, but recurrence is higher because it demolishes your microbiome. Fidaxomicin is modestly better at a giant markup, but you should try for it. And if insurance companies will pay for it, then I would do it. And fidaxomicin in this 5 days and then every other day is the best we can probably do based on the evidence. So consider that if they respond really well to therapy. So next I want to move on to this bezlotuximab that I've kind of teased. So immune therapy. So can we boost the immune response to C. diff? And we've known for a long time that antitoxin antibody seems important to C. diff prevention, or it's part of not getting recurrent C. diff. And previously we did things like give IVIG for refractory resistant fulminant kind of recurrent C. diff with not a ton of benefit. So why did we kind of go down this bezlotuximab pathway? Why did we start creating antitoxins? Well, a few things are having a lot of C. diff antibody means you're probably not going to be symptomatic with C. diff. So when they looked at people in the hospital on wards, what they found is people with a ton of C. diff antibody were often carriers. So they tested positive for C. diff with no disease, and they had very high antibody levels. People with low antibody levels fell into either people who were not colonized and fine, or people who had active C. diff. So having antibodies seemed to be fairly protective. And then also forming antibody was sort of the difference between people who had one episode of C. diff and people with recurrent C. diff. People with recurrent C. diff, even though they'd had infection recently, had terrible kind of nil antibody levels. But people who had a lot of antibody, which they usually form right around the time the antibiotics end, were safe. So they went about making antitoxin antibodies. They made an antibody for A, an antibody for B. So B, bezlotuximab. And they figured out antitoxin A antibody is worthless. But they found out antitoxin B antibody is pretty awesome. You know, more than 10% absolute risk reduction. And the other interesting thing about bezlotuximab that's nice is the more risk factors you have for recurrence, the more it seems to work. So if you had no risk of recurrence, you were the poor soul who was 25 and again got clindamycin for a tooth infection and got C. diff. If you were that person and then you never had any more healthcare, you had no benefit to bezlotuximab. You just had that 20% recurrence risk and that was it. Didn't help to give you an antibody because you probably formed antibody anyway. But when you start to become over 65, you're starting to have C. diff in the last 6 months already, you're immunocompromised, or you had a really severe episode of C. diff, then you're getting a lot out of it. And the more risk factors, the more you get. Sometimes up to 20+% absolute risk reduction, close to 30. And then also, just for fun, it's not clear that the antibiotic you use matters, that you may get the same kind of absolute risk reduction from Bezlo regardless of the antibiotic. So we don't know if you can stack the benefits of different things that reduce recurrence. But look, there was almost nobody with fidaxomicin. So I think more to come on this because sadly, we don't know if bezlotuximab and fidaxomicin are kind of synergistically increasing your protection. And the other fun thing about bezlotuximab was that it started as a 3-month trial, like all C. diff do, but they had a 12-month follow-on. And every single patient from the initial trial that had clinical cure maintained cure for an entire year. So the concern was the antibody would wear off and people would relapse, and that's just not what happened. The antibody lives in your system for about 3 months, and then it seems like that takes you out of the danger zone, and then sort of you can coast after that is the idea. It takes you out of that time where you're trying to reconstitute your microbiome. It helps give you buy time for you. And so bezlotuximab should be, which is an IV antibody given once in an infusion center through peripheral IV, should be given to anybody with a very high risk for recurrent C. diff, which is defined essentially as over 65, immunocompromised, severe disease with this C. diff episode, or recurrent C. diff. You can calculate severe disease by ZAR score, but you also know it when you see it. So really, this means that even people on their first episode of C. diff can get bezlotuximab, and I do recommend that in the highly immunocompromised people particularly, but anybody that you are pretty sure is going to relapse might benefit from bezlotuximab even with first episode, but literally everybody with a recurrent C. diff should be considering this. And really it helps early. Like most interventions to prevent recurrent C. diff, you have to nip it in the bud early. You get the most bang for your buck using them with the first episode of the first recurrence. The more recurrences you're going to have in C. diff, and the more it just transitions to being a pure, there's no microbiome left to save you issue. So use it in the first episode with high risk, use it for everybody with recurrence. Could you redose it? People don't know yet. The answer is it's safe and that most people are doing it. But if you have a recurrence early after you're giving it, it doesn't really make sense. You have all the antibody you have and your recurrence is for other reasons. So I would say if you gave Bezl and somebody did well, and then a year later they get antibiotics again and get C. diff, then that's the person I would be thinking about giving bezlotuximab to, because I'd say, hey, I think it worked. And then they just got it again later on. And no anti-Bezlo antibodies were found in early phase studies with multiple infusions. There's no proof it has any effect on the current. This is purely a recurrence prevention. And it was really hard to study, so they couldn't, predict any benefit. So your hospital wants you to give this in the outpatient setting, even if they're admitted for C. diff, because usually most people can come in and out of the hospital in a few days. So they want you to send them to an infusion center while still on treatment for the C. diff to get this, because it's a more than $2,000 infusion that they're going to have to eat otherwise. But in rare cases where somebody's going to be hospitalized for a particularly long time, maybe like a transplant that's having a hard time getting out of the hospital, there might be super rare indications to give it inpatient. And the only contraindication is there is a black box warning for people with severe CHF at baseline, that in the study there was higher CHF exacerbation episodes. It was statistically significant. It's probably how much fluid they were giving, and you can concentrate it more than they did in the study. And I don't think it's really played out that much in clinical care, but it is something to be aware of, this kind of black box for severe CHF. Finally, let's get to the hot topic, the microbiome, right? So microbiome targeted therapies to kind of break you out of your recurrence cycle. And this is a great picture that shows, you have C. diff, exposure, you deplete your microbiome. Antibiotics help get you feeling better for a little while, but they're discontinued. You still don't have those secondary bile acids. You still don't have a microbiome to save you. And you just get in this loop of recurrence. And you have to disrupt that somehow. And microbiome restoration is the best we have available. So microbiome restoration, AKA FMT, AKA FBT, aka stool transplants. So initially these were directly taking stool from screened donors. Either at one point it was you brought a donor, then it became more of a universal donor from a stool bank where they get screened for lots of infectious diseases. They're also not allowed to have particularly any medical problems that have in any way been thought to maybe be linked to your microbiome. Again, so neurologic things, GI issues, lots of stuff right now. So you have to be a totally healthy younger person to donate. So we were using the stool bank and it was going great. This was under an FDA IND, so it was not an FDA approved product, but they were pretty lax in saying, hey, if it's for recurrent C. diff, okay, just keep some records, tell us if something bad happens, and you have to have a clinical trial if you're doing anything other than C. diff. So it became, and they had lots of regulations for the stool bank that they had to do, but it became pretty lax and easy to give, but you had to do a consent and all that. Well, not having an FDA approved product eventually led to somebody seeing a market. And so we now have FDA approved agents, and they call this the live biotherapeutics category now. And so this is just the next stage in microbiome restoration therapy. And the two options right now are fecal microbiota spores, live BRPK, VOWST, or oral encapsulated which are really oral encapsulated Firmicutes spores sent right to your home. So you don't have to even go anywhere to get your FMT. Or there's this fecal microbiota live JSLM, which is an enema product. And both these live biotherapeutics are treated as drugs. So there's no longer a consent. There's many less barriers to giving them to patients, except for cost. So when you go from something that was run by a not-for-profit to a for-profit entity with an FDA approval, the cost goes up. So let's have a spore fight. Let's talk about the spores. So we got C. diff and its spore forming ability. versus Firmicutes and their spores. So fight the bad spores with the good spores. So the live capsules, so they start out like traditional FMT, live screen donors, all that stuff, but they have an extra step where they ethanol wash the stool for 2 hours and filter it. And so you get down to what's essentially just some Firmicutes spores, which are good bacteria. And the good thing is these are shelf stable. The data shows that these are killing off bacterial MDROs, viral things like HSV and other herpes viruses, and seemingly COVID, fungus, parasites. So it looks like you can kill off almost anything you wouldn't want transmitted with this ethanol wash and get down to just what you want. So this is like a probiotic on steroids. This is what probiotics wish they were. And the data shows good engraftment within about a week, good growth of Firmicutes spores, and a shift in bile acid profile. And there was no infectious complications in a study to date, but that is not surprising because regular FMT is profoundly safe, though this could in theory be an even safer product. And so the trial, this was multiple recurrent C. diff, 3 or more episodes. And at 8 weeks recurrence, you had 12% recurrence versus 40% if you got no FMT. So this was standard of care antibiotics and then FMT at the end or no FMT at the end. And you did have a reduction in recurrence. So, and it's not as good as we were hoping. Everybody was telling us, oh, FMT is 90% effective. Well, it's 90% effective if you're willing to do as many FMTs as it takes to get rid of the C. diff, but 90% was too good. Sometimes FMTs don't work. Sometimes you need more than one. So this is a more reasonable estimation of the risk reduction. And then when they went on to an open label trial where everybody got FMT, you had to have 2 or more episodes of FMT. And unsurprisingly, the outcome was even better, only 8% recurrence. So, and the big thing was it was safe. So again, no serious adverse events, but GI adverse events that were mild or very common. These don't necessarily work as instantaneously as traditional FMT. You kind of have to have it grow up in your gut and fight. So people often feel kind of junky for the first week, but by 2 weeks, they should have normalized and be doing great. If they're not, they're probably recurring or haven't had a good outcome. And so the actual process of this is fun. You see the patient, they have C. diff, you prescribe antibiotics, and you order the FMT at the same time. You fill out the paperwork, and they continue at least some amount of low-dose standard of care antibiotics until the FMT comes in the mail. So then now that they have it in hand, they stop their antibiotics for 48 hours, try to wash the antibiotic out of their gut. You don't want to kill off the good new stuff. The night before, you take a mini prep, which is like a bottle of mag citrate or a couple caps of Miralax. And then you start every morning on an empty stomach, you take 4 capsules of the microbiome product for 3 straight days. And then you've had your full FMT at home and you didn't have to buy a blender or do anything weird or gross. Like the olden days. So the process is currently messy because this is an extremely expensive agent, talking about $14,000 almost. So insurance companies are trying not to add it to their formulary yet or dragging their feet, or there's argument back and forth about who's going to pay for it. There's actually a great copay assistance program through Nestle, but the good things about this in theory and in the future are there's no restriction on the ordering provider. It's widely available. So it should take away the gatekeeping and the barriers to MRT. Like people are having to go to a quaternary or tertiary care center to get FMT. And that's just not the case now. This is a drug anyone can order. So hopefully C. diff treatment is improved by having these live biotherapeutics on the, available widely, but the cost is a concern. Conversely, here's the enema product. And what it showed was the phase 2 actually didn't work. It didn't meet the pre-specified. So it helped a little, but not as much as they hoped. So they did a much larger phase 3 study. So this is again, multiply recurrent C. diff with a single enema to prevent recurrence. And they got about 20% versus 40% recurrence at 8 weeks. So, and the cons of this, the reason it's not super popular is because you still have to have a visit. You still have to come somewhere. It's semi-invasive. You're getting an enema, so people rarely pick it. And maybe it's even slightly less effective, but again, it's not a head-to-head. It's just 2 studies that had similar entry criteria. So the pros are, again, just that this is a widely available thing. So this decreases barriers and it gives us more than one product on the market at the same time, because we experienced before, when we only had one national kind of FMT source, that it dried up, and then none of us had FMT to give for over a year when OpenBiome had problems before. So, and it's cheaper than the oral FMT, but still wildly expensive. So it's good to have more than one product, but people don't like to choose this. So right now, logistically, the oral product is wildly popular. So how do you choose an MRT product? Well, I used to offer them even traditional FMT. Right now, that's off the market. So the FDA said, hey, OpenBiome, slow down. Your IND is expired because there's several FDA approved products that fill the role we were letting you fill with an investigational drug. So right now they are kind of circling the wagons, and the idea is they're going to now only give product for inpatient acute use. So salvage, which we're going to talk about in a minute. So really right now you talk about oral and enema. Can they swallow pills, or do they need an enema? And then really it comes down to what's available and what can I get covered, and choose that. But you kind of talk them through all these. This evolving thing that you should just know about is that people are using MRT, microbiome restoration, FMT, for refractory and fulminant C. diff in the hospital now. And it's an emerging use because, you know, there's not a good definition for refractory, but usually about a week of therapy doesn't fix it. But fulminant especially is where the kind of the money is, although it's a rare but devastating consequence. You're talking about an 80+% mortality condition. So people who get fulminant C. diff die all the time. And the best approach was surgical, which had over a 50% mortality, operative mortality. And there was a surgical procedure called a loop ileostomy with retrograde vancomycin lavage that showed lower mortality at one center. But it turned out, when you look harder, it's not clear that the surgical approach matters. But it is clear that it's a fine line of when to do surgery, and it's very morbid and potentially fatal to need surgery for C. diff. So there's clearly a need to do better. And Monica Fisher created this protocol from IU where they were giving oral vancomycin for at least 48 hours. Then they would do FMT via scope. They'd look for pseudomembranes. They'd give an FMT regardless of pseudomembranes or no. But if pseudomembranes were present, they'd restart oral vanc. And every few days, they would check again by colonoscopy and give an FMT every time. And when the pseudomembranes finally resolved, then they didn't restart vanco. And in that, they cured 100% of people with severe C. diff and 87% of people with kind of fulminant C. diff. So they flipped the mortality and the cure numbers, essentially. And this has been shown from other people. Iannaro in Europe had a fairly similar outcome. The average is you're going to get about 2 FMTs in the hospital. But it's still like in its infancy. We don't know, should you give antibiotics after? Should you not? Would fidaxomicin be better? Like, you could start vanco, but switch to fidaxomicin for its narrower spectrum. So there's a lot of future studies needed, but there are already some studies showing other places adopting this and getting good outcomes as well. And it's even been added to the AGA FMT guideline from this year. But really, this is a good area where people that are very sick with C. diff or not responding to C. diff therapy really need multidisciplinary assessment by IDGI and surgery. And we even have a multidisciplinary working group addressing this at UW. Probiotics, I don't really want to get into this. Other people have given you grand rounds even on probiotics, but the fact is they're not recommended by professional societies. They may slow down your microbiome reconstitution. In the ICU, bacteremias occur. You open those little probiotic capsules, you get them all over the central line. There's going to be a couple bacteremias every year. They're not super harmful, but they're not beneficial at all for recurrence of C. diff because they're too simple of a solution to a complex problem. You burn down the whole forest and then you plant one plant that might or might not be alive. God knows what you get with these products. And then you're like, no more C. diff will ever come. And so the spore forming demon wins. Probiotics are what basically the new oral FMT wish they were. And if people really want to use them, I always tell them to eat yogurt. Eat your nutrition. At least yogurt is healthy. It does show some benefits in decreasing antibiotic-associated diarrhea. So Greek yogurt, kefir, something along those lines is better for you. It's a better use of your money and time, and I try to drive people in that direction. But ultimately, I don't really care if they take probiotics, but they're not good. And I don't think they have any place in the hospital, truthfully. I think they're voodoo, and it bothers me that we spend millions of dollars a year on them. Secondary antibiotic prophylaxis, again, is a little too early to comment too much on. It's extremely prevalent at our here and abroad. Low-level data suggested maybe it decreased recurrent C. diff rates. There's really not been good evaluation of the potential harms of it. The studies are very heterogeneous in how you put people in, how long you do it, how often, and everything. We don't really have good fidaxomicin data, which might be the best of both worlds. We've completed an RCD of oral Vanco versus placebo, and stay tuned. But I really think the data is bad for secondary prophylaxis, and it's not around for a long time. But it's still super common in practice. So somebody who had C. diff over the course of their lifetime definitely doesn't need secondary prophylaxis. I would keep it within, 8 weeks, 3 months, some number, but you got to cut it off at some point because it's also bad for them. Antibiotics are still bad for you. So my treatment takeaways that I really want you to focus on are focus on therapies that reduce the risk for recurrence and use them early when they still have the possibility to make a difference. Again, fidaxomicin if you can, bezlotuximab if it's appropriate, particularly by the first recurrence. And then if you're into multiply recurrent, you're into microbiome restoration land. And it should also be considered in severe fulminant refractory C. diff in the hospital. So feel free to engage that multidisciplinary team when you see a bad case of C. diff, because we have more things than we used to, and it's very possible we can help. So thank you so much. I love talking about C. diff. Everybody's tired of hearing it. So thank you for being another group to listen to me. Contact me anytime.
Thanks, Chris. That was awesome. Got several good questions in the Q&A. Can you see those, Chris, or do you want me to read them for you?
Why don't you give them to me?
Okay. For inpatients with C. diff, can we use fidaxomicin instead of vancomycin every time? And do we need stewardship approval to use fidaxomicin?
Great question. So fidaxomicin only works if you can go home on it. So right now, the way we have it set up is the pharmacist can check if they can afford fidaxomicin, and if they can, then the stewardship team will approve it. So it's only being called because we need people to find out if they can pay for it. The other things to think about is just if they're on meropenem for weeks and weeks as well, I'm not sure fidaxomicin offers any benefit at a high cost. So if their microbiome is demolished by concomitant antibiotics they have to have, we might think about maybe this isn't the person that this is the best use. But fidaxomicin is pretty easy to get as long as the patient can go home on it. Then we're happy to give it in the hospital.
Sort of a related who can order it question. This time for bezlotuximab.
Yeah, exactly. So bezlotuximab's theoretically orderable by anybody. It's just a, outpatient infusion. People aren't used to ordering outpatient infusions, and there are certain insurance companies that throw a fit if it's not an ID doctor. So it may need to be an ID or GI doctor that orders it, but that's not automatic. So you can try to set it up on your own if you're comfortable. And again, our ID pharmacists have helped people set it up as well, but it should be orderable by everybody, but it's the real world too.
Okay. So this is a little bit of a complex question related to the fidaxomicin versus vancomycin. It says, in your opinion, does the degree of perceived benefit of fidaxomicin over vancomycin change in patients with an already disrupted microbiome from significant antibiotic exposure, or in patients that will need to continue antimicrobials after CDI treatment and will continue to have microbiome disruption?
Yeah, it's a great question. We legitimately don't know the answer because there's two ways to talk about this. One is that when in the trials, people who are on concomitant antibiotics had a better outcome with fidaxomicin than people who are on vancomycin, but not by a lot. So you could argue it that direction that fidaxomicin is still beneficial. The alternative is when people are going to be on antibiotics for a long time, we're often tempted to not stop the C. diff treatment till the antibiotics end. And legitimately, you're probably already destroying their microbiome. So I wish we knew the answer to this, and this is an area that needs further study. I tend to lean toward just using Vanco in those cases, just realistically, and continuing their Vanco till a few days after their systemic antibiotics stop. I think that's the usual practice of an ID doctor. But it's still TBD.
Great. Here's a question related to probiotics. So specifically, should we just take them off of the hospital formulary?
I've said that several times, but it hasn't been my role in any. But yeah, I think we should. We've talked about it. It's not clear whose role it is to remove that. We've talked about it in the stewardship group, and it's a big thing because people seem married to their probiotics for no particular reason. But I would advocate that we could save a few $1,000,000 and have no harm associated with removing them. But I'm far on the anti-probiotic spectrum compared to a lot of people that just don't want the fight. And in peds, I hear it would be a dramatic fight, so I'm not going to delve into that because then you got parents on top of it, not just patients themselves.
And there is that ambulatory use in recurrent UTIs now where there may be some benefit, but
Yeah,
anyway.
It's not real, but
yeah,
they say it.
Jim Conway wonders, what's the latest on the vaccine?
So the development stalled. Periodically, they've tried to get a C. diff vaccine, and it would be awesome if it worked, but it's not been easy to make work. There's been some low-level benefit, but not to the efficacy that they thought they could market it. So I'm not actually sure where we're at with if there's a good candidate right now, but there's been candidates over time and not a great outcome, not zero efficacy, but not enough to make, the papers or make the market.
Great. Well, I think that's all the questions. Thanks again, Chris. That was really awesome.